Thank you for joining this tutorial on coordinated entry for Minnesota Housing PSH projects, or permanent supportive housing projects. I'm Matt White with Apt Associates, and I've been engaged by the Minnesota Housing Finance Agency to provide this information to you. Let's start with a definition of coordinated entry. Coordinated entry is a centralized or coordinated process designed to coordinate program participant intake, assessments, and provision of referrals. The coordinated entry system covers the geographic area, is easily accessed by individuals and families seeking housing or services, is well advertised, and includes a comprehensive and standardized assessment tool. This definition is taken directly from the Continuum of Care Program Interim Rule. This is a HUD requirement for all continuums of care. Let's talk a little bit about how coordinated entry systems, or CES, fit into the continuum of care process. Coordinated entry, as you can see from this slide, is represented by the blue bar on the far left hand of the screen. It represents the entry point or front door into the crisis response system. A crisis response system typically provides prevention or shelter diversion assistance in addition to temporary shelter. And temporary shelter can be an emergency shelter, a faith-based provider, day space, maybe vouchers for motel use, any kind of safety net service for persons who are literally homeless. Often these persons need some amount of assistance to end their homelessness, and this can be in the form of rapid rehousing using existing landlords and short-term financial assistance, or transitional housing. Transitional housing is often project-based or site-based housing for an extended period of time, but not permanent. These two interventions both lead the participant to permanent housing. The permanent housing is represented by the yellow bar on the far right hand of the slide, and it includes community-based permanent housing and community-based services and supports. For some persons who have long-term homelessness and a disability, permanent supportive housing is required in order to help these persons achieve permanent housing and sustain their housing placement for the long term. So how does coordinated entry fit into this? It helps these crisis response systems achieve their goals. The system goals are that homelessness is rare. For persons who are experiencing a housing crisis, we want to try and identify them as quickly as possible and prevent or divert them from homelessness. But in some instances, that's not possible, and some people will come into the crisis response system or come into the continuum of care. And for those persons, we want homelessness to be brief. And for people who leave the crisis response system, they're able to get those safety net services that they need to resolve their housing crisis. We want to ensure that homelessness for them is not recurring, that they don't come back to the homeless system again after recidivating. Let's talk further about some of these goals. The coordinated entry goals, as defined by HUD, promote these various attributes that are listed on the screen here. We want coordinated entry to be client-centered. This means that the approach to engagement, assessment, prioritization, and referral and linkage is all focused on the client's needs and, as much as possible, the client's preferences. We also, through coordinated entry, want to ensure that we're prioritizing the persons who are most vulnerable. We'll talk much more about prioritization in a bit. Another goal of coordinated entry is to eliminate barriers to housing placement. These barriers can often be in the form of requirements for sobriety, income, or participation in services for clients before they're enrolled, or their agreement to participate before they're considered eligible for a housing project. Another goal of coordinated entry is to foster decision-making transparency. How decisions are made about who is prioritized, who is referred, and how enrollment decisions get made. We want all of that to be transparent and those decisions to be easily understood by all involved. Of course, we want to use data throughout the process of coordinated entry to understand if the system is effective and if it's efficient, and if it's not, how we might use data to improve the system of care. This is all in an effort to comply with the HUD mandate. Any homeless assistance project that receives Continuum of Care funds or ESG, Emergency Solution Grant funds, is required to participate in coordinated entry. Let's review some of the core operational components of coordinated entry. The first, access, refers to the entry point. In other words, this can be considered the front door to the crisis response system, how people become aware and enter the continuum of care. The second operational component is assessment. This is the process of documenting participants' needs and their preferences through a standardized assessment process or assessment tool. The third component is prioritization. Unfortunately, most continuums of care don't have a ready supply of housing assets so that they could house every single person who is requesting services. It requires that persons are ordered or prioritized for assistance. And HUD suggests that this prioritization be based on the greatest need. And then finally, the fourth operational component is referral. And this is the linkage process, finding available housing assets or services in the continuum of care and linking or enrolling participants who are eligible for those housing and service slots. Because HUD requires all continuums of care to implement and manage a coordinated entry process, each continuum of care might make somewhat different choices about exactly how they're going to design and operate their systems. The state of Minnesota recognized that it would be very useful both for homeless persons themselves, for homeless assistance providers, and for housing property managers to experience some standardization in the way that the state manages coordinated entry. For this reason, the state of Minnesota undertook a strategic planning process to define common baseline standards for coordinated entry system design, operations, and management. And these standards were then established across the entire state of Minnesota. Each continuum of care is required to comply with these statewide standards, although some continuums of care may refine their approach within the statewide structure. Let's talk again about some of the basic requirements of coordinated entry. HUD, in their Continuum of Care Program Interim Rule, explicitly identifies 6 basic requirements. They're listed on the slide here. The first is that coordinated entry systems must cover the entire geographic area of the continuum of care. Second, coordinated entry must be easily accessed by persons who are seeking assistance. Third, it must be well advertised. This is so persons who are homeless know where to go, and community-based providers know where to send or refer people. 4, coordinated entry must incorporate a standardized and comprehensive assessment tool. Related to that is number 5. They must then use that standardized and assessment tool to apply a consistent process for documenting clients' needs and preferences who are seeking assistance. And then finally, 6, every continuum of care must promulgate policies and procedures which guide the operation of their coordinated entry system. These policies and procedures must specifically meet the needs of families and individuals who are fleeing domestic violence and who are seeking assistance from the continuum of care. These 6 basic requirements are established by HUD. In the near future, we expect HUD to release more standards, but these 6 standards have all been adopted by continuums of care in the state of Minnesota and will be adding to these basic requirements in the coming year. Let's talk about coverage. What do we mean by coverage? Coordinated entry operations must cover or essentially serve the entire continuum of care geographic jurisdiction. That means that if there is a designated front door or access point or entry into the system of care, It must be accessible throughout the entire geography. An example would be a central city that has an emergency shelter which acts as the front door or the entry point. But that central city is surrounded by suburban and maybe even rural areas throughout the whole county. This first requirement of coverage indicates that the entire county has to be covered by front door services. This can be accommodated by establishing hubs or regional intake points. In other instances, counties may elect to use a crisis hotline or maybe a 211 information referral line to provide coverage throughout the entire continuum of care geography. The other thing to remember about coverage is that there can be different access points or different front doors for each subpopulation. There are 5 different subpopulations listed on the slide. HUD allows differences for entry into the continuum of care for each of these: single adults, households with children or families, youth, households fleeing domestic violence, and veterans. There are also requirements for the use of standardized access points and assessment approaches. We've already talked about access points and the specific subpopulations that are covered in each. I now want to talk about standard operating procedures, or SOPs, that describe how the coordinated entry system is going to operate. They must describe not just the assessment tool itself, but the process: who's administering the assessment, what information gets collected, how is that information used, is that assessment information shared with other providers. All of those would have to be outlined in the standard operating procedures for assessment. In addition, the CSC will have to establish criteria and a process for how they're going to prioritize persons for assistance. Remember earlier we mentioned that in many instances, a continuum of care does not have sufficient housing resources to meet the demand of all persons who are homeless. In these instances, the continuum of care will need to prioritize the fixed number of beds and allocate those resources to persons with the greatest documented need. This prioritization process is often accommodated through a scoring process. Questions about need, vulnerability, or intensity are assigned a score. When clients answer affirmatively to these questions, the score sums up their total need or prioritization amount. That score then aligns with an order for how persons will be referred to available continuum of care housing. Let's talk a little bit more about the use of this standardized prioritization process. The scoring process, as I've mentioned, essentially assigns a numeric value or a number to each of the questions that a client answers affirmatively. The written standards for administering assistance needs to very clearly document how those numbers, how that score is calculated, and how a score then aligns with a referral to a particular housing strategy. These written standards need to be very clearly established, publicly available, and the continuum of care is encouraged to revisit them on a regular basis to ensure that the allocation of fixed continuum of care resources continues to meet the demand or the alignment of demand for clients coming into the system. Another requirement is that continuums of care lower barriers. These are often documented in the standard operating procedures for coordinated entry and describe how projects are going to adopt a housing-first program approach. Again, this standard applies to continuum of care funded and ESG funded projects. Those projects are encouraged to reduce barriers, to eliminate preconditions for enrollment into their projects. These barriers or preconditions might have to do with requirements that a participant be enrolled in services, that a participant be sober, that a participant be actively engaged in treatment services, or a participant has income. All of those preconditions represent barriers to entry for many clients. The goal of coordinated entry and of Housing First is to reduce those preconditions and lower the barriers to entry into continuum of care resources. Another requirement is that through coordinated entry systems, all projects develop an affirmative marketing strategy. This affirmative marketing strategy is also documented in the Continuum of Care's written standard operating procedures, or SOPs. Essentially, we're talking about ensuring equal access to coordinated entry systems regardless of any federally protected Civil Rights Act class. These include race, color, national origin, religion, sex, age, familial status, disability, actual or perceived sexual orientation, gender identity, or marital status. This complete list of protected classes represents how continuums will operate in ensuring equal access regardless of a participant's membership in one of those categories. We also want to ensure that different homeless subpopulations have equal access as well. Those subpopulations could include chronically homeless persons, persons who are veterans, families with children, youth, and survivors of domestic violence. In addition, all access points or front doors or entry points into the crisis response system to the continuum of care have to be accessible to persons with disabilities. They also have to be accessible to persons with limited English proficiency. Continuums of care are encouraged to engage in translation services or other support services to ensure that persons understand the continuum of care and the standard operating procedures for participation in the coordinated entry system. Another requirement for coordinated entry is that it be integrated and coordinated with street outreach. Street outreach is a program that is intended to identify and engage persons who are living outside, persons who are living in areas not meant for human habitation. By engaging and coordinating with street outreach, the coordinated entry system can ensure that all persons experiencing homelessness have access to standardized assessment and access to continuum of care resources. Emergency shelter services also must be coordinated with the coordinated entry system. Most coordinated entry systems will use an emergency shelter as an access point, but in those continuums of care that have a different access point, maybe it's 211, a crisis hotline, or some other information referral hotline, and then the person is referred to emergency shelter, there can be no prioritization for emergency shelter in those instances. Emergency shelter is a crisis response, and all emergency shelters are encouraged to flexibly change their configuration to accommodate the demand for persons who are literally homeless so that no person is forced to sleep outside or on the streets. Again, emergency shelter assistance is not prioritized. Any person who is experiencing literal homelessness should be afforded access to that crisis response system. What are the requirements around referrals? This requirement becomes especially important for our multifamily housing and other housing property managers that are choosing to participate in coordinated entry. And it establishes uniform referral processes. Typically, there is a manager of the coordinated entry system in the continuum of care, and that manager is keeping track of all of the available openings or housing slots that will likely become available in the near future. As a property manager or property owner, your obligation is to let that coordinated entry referral manager know about an anticipated opening before it occurs. Maybe you have a unit that's turning over, and in 3 or 4 days or a week, that unit will be available for someone new. You'll notify the coordinated entry referral manager, and let them know the specific eligibility criteria, the program design, and any other attributes associated with that housing so that a potential participant would be able to make a determination about whether or not that's a housing option that they want to pursue. In order for us to manage the list of people who all need housing at the same time, continuums of care will maintain a prioritization list. As I mentioned before, this is a change from the way continuums of care have historically operated. There are two significant changes. Number one is there is a centralized list for the entire continuum of care. No longer will each individual housing project maintain their own separate list, but a single centralized waiting list or prioritization list for all continuum of care housing assets will be managed by the referral coordinator. Number two, each continuum of care housing project will not be able to accept persons into their program unless they are referred through the central intake or the coordinated entry system. The coordinated entry process prohibits these projects from maintaining separate or individual wait lists for their own projects. They will be taking referrals from the community's centralized prioritization lists. Again, this refers to all of the continuum of care and ESG-funded projects which are mandated to participate in coordinated entry. For a housing provider or property manager that is choosing to participate but not mandated to participate, you're encouraged to follow this same requirement, that the homeless persons who are filling the available slots are coming directly from the community's centralized prioritization list and not from a separate individual waiting list that the housing project maintains independently. So let's talk about how to participate in your coordinated entry system in the continuum of care where your housing project or the property is located. First, you'll want to learn about the local planning process. As I've mentioned before, although there are a set of statewide standards for coordinated entry, each continuum of care has established unique prioritization, assessment, and referral standards that reflect the local needs, local capacity, and all of those local decisions are written and publicly available. So you want to make sure that you're participating in the planning process and that you have access to those written materials. Second, in order to ensure that you're getting appropriate referrals from coordinated entry, you should share any program eligibility guidelines. These eligibility guidelines could be a result of a funding source that's supporting operations or the development of the project, or they could be a function of the design of the project itself, its location. Sharing the eligibility guidelines will ensure that the referrals you get from coordinated entry are well aligned with your program design and it supports the client's access to housing in a speedy way. Finally, set up communications so that you're sharing information about vacancies or upcoming vacancies, that you're communicating whether or not you're accepting the referrals that you're getting, and any concerns that you have about the coordinated entry process. That feedback loop and sharing communication will help ensure that your coordinated entry manager is using the information about your experience with coordinated entry to make adjustments and improvements in the system. And you'll also want to engage your funders on any policy or requirement changes and reporting expectations related to coordinated entry. We're interested in making sure that homelessness is rare, brief, and non-recurring, and ensuring that coordinated entry functions efficiently and effectively for all property managers. So we hope that your experience with coordinated entry is successful and that you are able to identify and quickly enroll clients that are a good fit for your programs. Thank you for listening to this tutorial on coordinated entry.